My name is Tim Gibbs with the Delaware Academy of Medicine and the Delaware Public Health Association, and I'm going to moderate this morning's panel discussion in that I'm going to introduce the speakers. I'm going to kick off with a couple of questions, and then it is up to you all to raise your hand and to participate as well. I can't carry this alone, and I have a sense that there are a lot of questions. So first we have our panelists, Conyngham. Caitlin is the program director with Philadelphia FIGHT, Youth Health Empowerment Project, YHEP for short. YHEP is a comprehensive adolescent and young adult program that offers holistic health services, sexual health education, drop-in day services, and leadership activities to over 3,000 high-risk, high-promise, low-income urban youth individuals, 13 to 24, living in Philadelphia. Next, we have Dr. Deborah Kahal, MD, MPH. Dr. Kahal is the HIV program physician here at Christiana Care Health System. She's conducted HIV/AIDS research, co-authored an article published in AIDS and Behavior, and presented lectures, teaching sessions, and grand rounds at HUP, University of Pennsylvania Perelman School of Medicine, FACES, which stands for Family AIDS Care and Education Services, UW Medical Center Psychiatry Conference in Nairobi, Kenya, and the Tulane School of Medicine, which I'm assuming is in Louisiana. And finally, we have Lisa, and I'm going to do this right, Skedzielewski. All right, woo! Who is a PharmD. And Dr. Skedzielewski is the pharmacy manager at Walgreens. So if you could join me in welcoming them, and we'll get to questions. Okay, who's been good today? Who shall we start with? I think I'm going to start with the one that has the most difficult name to pronounce. Okay. This is targeted to you. All right, so Lisa, who pays for PrEP, and what are the medication assistant programs available for Truvada? Are there side effects or drug interactions, contraindications, or any other warnings that you would counsel your patients about in the pharmacy setting?
Caitlin and I were just actually talking about PAN. They are currently not accepting new patients right now. They might start re-enrolling soon, but as of right now, they are not. There's the Patient Advocate Foundation, which covers a max of $7,500 a year. All of the websites' phone numbers are all listed on the bottom. And then there's also the Chronic Disease Fund, which Gilead notified me about. We've never had to refer a patient there yet. So those are all three, and if they get denied by any of those and they can't get proper funding, you can file, it's called a special exception through Gilead. Basically, you have to write why they were rejected and what the circumstances are, and most likely they will be covered. If they have Medicaid, Medicare, it's typically just a prior authorization, and they will be covered. And if they have no insurance, then they will go to the Gilead MAP. So that is the Advancing Access Program. So they fill out the MAP form online. The doctor can do it over the phone. It's very simple. And most of the time, as long as they're under, I think it's between 138 and 500% below, or of the federal poverty level, they will be covered 100%. So that refers to, and if anyone has questions about if you have a problem patient or anything like that, you can always contact me or some of the other Walgreens pharmacists. We can help you with prior authorizations and things like that, coverage. Now, the second question.
Drug interactions, contraindications that you would counsel.
Truvada is a very mild medication. I would say the most frequent side effects that we see with patients are any GI problems, headache, things like that, but they typically go away after the first, I would say, 3 or 4 weeks of being on the medication. Now, drug interactions, you're going to get me like a little tricky here. So, it obviously depends on the patient, what they're currently taking. It doesn't really interact with many medications. I know it interacts with hepatitis. I don't know if you can help me on this one. Hepatitis adophavir. There's no other really contraindications with the drug. That's why it's so great, because it's a very well tolerated, and it's a great medication.
Okay. And certainly at any point as we're having this panel discussion, if they're physician or pharmacy experts that can add to the knowledge that we're getting from the panelists, raise your hand and speak out. One of the follow-up questions would be, I understood Dr. Urbina to say in his opening comments that about 1% of people have a little bit of bone density loss.
Yeah, but that doesn't really affect, like it doesn't increase fracture risk at all.
Right, okay.
And it's very uncommon.
And so if they were taking any drugs for bone loss, they would just continue that as normal, presumably. Good question.
Yeah.
I mean, feel free to chime in, anyone from the audience, but I think if you're considering starting PrEP Truvada on someone who has known osteoporosis who's being treated for such, that would be, you'd have to weigh the risk and benefits, and that's a conversation that you'd want to have with that particular person. Overall, there's no general umbrella recommendation to do a DEXA upfront before starting to screen for osteoporosis, unless someone has pre-existing risk factors, a known fragility fracture. But just in terms of all comers, there's no upfront recommendation to do screening DEXAs on patients who you're considering starting Truvada on.
Okay. Caitlin, how can case managers of HIV/AIDS populations engage in conversations regarding PrEP as a tool for HIV risk reduction? In other words, how can we empower and encourage our clients to have these conversations with their sexual partners? Can you talk a little bit about your patient advocacy successes in Philadelphia? How many clients does Philadelphia Fight currently serve?
Great. That's a lengthy question. Thank you. So I think one of the things...
Say it would be easy.
Yeah. One of the things that I would really encourage and challenge everyone to consider and think about when we're thinking about PrEP and the landscape of PrEP and prevention and HIV prevention is really that I think PrEP is an opportunity to think about pleasure and to think about sex and sexual health and safety in really different ways. And I think for me and for a lot of the folks that we see in clinic and we talk about, I think Dr. Koenig spoke about, we often think about HIV testing and we link our folks that test positive to care, right? And we don't often think about linking folks who test negative to care. We say, see you in 3 months, see you in 6 months, good luck. Right? We'll see you for your next HIV test. But really, I think that PrEP is an opportunity to engage for a linkage, right? So Dimitri Daskalakis says that PrEP is a gateway drug to primary care. And I think that it truly is. So I think when we think about PrEP, it's an opportunity to link folks to engage in healthcare, engage in conversations about sex and pleasure, in conversations about things that you may not have, right? So when's the last time you talked about what's the best sex of your life that you've had with your patients, right? And I think that's a really good gateway question, right? So you don't have to necessarily say you are at risk for HIV, PrEP is a good option for you. You can say, how's your sex life? And wait for that answer. And if the response then warrants, like, tell me about great sex that you're having. What is it like for you? And if the response is like, great sex for me is not using condoms, we may need to sit with that as providers. Or we may need to sit with hearing that if great sex for the folks that we're seeing in clinic is not using condoms, a really great bridge to working on having conversations about changing condom use might be PrEP. Right? Because I think that we can continually chat with the folks that come into clinic about PrEP adherence, engaging in PrEP care, also talk with folks about using condoms, about what are STIs, right? Because we know PrEP doesn't protect against STIs, that chlamydia and gonorrhea are real, right? And so we can continue to have those conversations while also talking about PrEP. And so I think that those are really important conversations to have, but we can't be afraid about talking about sex, about talking about pleasure, about asking really difficult questions, because condom negotiation sometimes isn't easy. It's not possible. It's just not on the table, or it just might not be something our clients want. And so if we're not willing to engage in those conversations, if we're not comfortable having those conversations, I think it's a real barrier to thinking about the ways in which folks may benefit from PrEP. I think the other thing, and then I'll wrap up, is that we sometimes pre-select who we think is a good candidate for PrEP, right? And so I think that limits who we then talk to about PrEP. And so for us, we talk to every patient, every visit about PrEP, regardless of who you are, regardless of what you look like, because it doesn't necessarily mean that you initiate that person on PrEP, because everyone probably knows someone who may benefit from PrEP, whether it's their sister, their best friend, whether it's someone in their community. And so it could be something as easy as right after you've had those conversations about folks' sex and folks' pleasure and all of their sexual health, you can say, have you heard about PrEP? It's a pill that prevents HIV. And many, many people have not. And I think that folks, there's usually two responses. Shock, right? This kind of like, what? There is a pill that prevents HIV. And then the second response is, how come I don't know about this? And so after the kind of shock of why, like, what are you talking about? There's the, how come I don't know about this, and why do I feel like I'm being withheld information? Why don't the people I love know about this? And so I think it's really important that we as providers don't look at the person that's in our exam room, or don't look at the person that we're testing for HIV, or don't look at the people that we're sitting in our case management office and not offer information about PrEP because we don't think that they're the right candidate, right? Because whether or not they might be a person that wants to start PrEP, they might date someone that might be a good candidate for PrEP, they might be the best friend of someone, or they might just be a really great, like, we all know that person that is like the information sharer in the community, right? And so they might be that person that shouts the information about PrEP from the rooftop. And so that person should have information as well, because the world needs to know. And so I think it's really important that we just disseminate information and do it in a way that's effective and not because of the glasses of who we think is at risk, or what's in the checkbox table of the guidelines.
I would add to that, when Dr. Biener and I were driving back up to Wilmington, he, by the way, had to catch a train and get back up to New York City, and Helena Kwakwa was unable to join us as well due to patient responsibilities. They both would have been up here. But Tony was saying that he's got patients, a number of patients, who are in their 80s and 90s. He also mentioned the disabilities community as being another community that, just because in our well-abled, relatively youthful capacity, we identify each other's as being potentials, doesn't mean that there aren't a lot of other communities as well.